Good afternoon and welcome to today's webinar, COVID-19 Data Sharing for Public Health Surveillance, Investigation, and Intervention, brought to you by the Network for Public Health Law. I'm Charles Strong, the Digital Marketing Coordinator at the Network's National Office, and I'll be your host for today's webinar. A quick note that both the presentation slides and video playback for this event will be available on our website shortly after the conclusion of today's webinar. We strongly encourage attendee participation and would love to hear from you, so feel free to submit your questions at any time during this webinar by using the Q&A tab on the right-hand side of your screen. All you need to do is click on that tab, select all panelists from the drop-down menu, and send us your questions. We'll be addressing them during the Q&A session during the second half of today's event. Your moderator for today is Jennifer Bernstein. Jennifer is a Deputy Director with the Network's Mid-States Region Office, where she provides legal technical assistance on a variety of health topics. Her current work focuses on public health data, adults at risk, maternal and child health, and statutory and regulatory public health. Jennifer will be leading us through the rest of today's webinar, so Jennifer, over to you.
Sorry, I think I was muted. Our speaker today is Sallie Milam. She's a Deputy Director with the Network for Public Health Law Mid-States Region. Her focus is navigating law to share data within and across sectors to address health equities. Sallie has practiced law for over 30 years, primarily in the health, HIPAA, and general privacy areas. She is a certified information privacy professional with U.S. and government privacy certifications. Sallie has extensive experience in working with state agencies around data. From 2003 to 2018, Sallie served as West Virginia's Chief Privacy Officer and led the executive branch's privacy program. Previously, Sallie facilitated data sharing through her service as the West Virginia Healthcare Authority's Privacy Officer and as a HIPAA Senior Legal Counsel, where she led HIPAA privacy implementation across the West Virginia Executive Branch. Additionally, she is the first Executive Director of the West Virginia Health Information Network, which is West Virginia's statewide health information exchange, and was West Virginia's Project Director for its nationwide Health Information Network contract. I will now turn it over to Sallie.
Hey everybody, glad that you're with us today. As you know, we are the Network for Public Health Law with public health attorneys across the country. And as you can see on the screen, our national office is in Minnesota. The network promotes and supports the use of law to protect the public's health by providing free, direct technical assistance, developing and providing training, materials, and practical tools, and connecting individuals with one another to build a public health law community. Jennifer and I are both in the Mid-States region, and we focus on navigating law to share data within and across sectors to address health inequities. We are not your lawyers. We are providing educational advice. So for legal advice, you need to talk with your own counsel. So today's agenda, as you know, we have an hour and we're going to be moving really, really quickly. We're really focused on answering the question, what can public health share around COVID-19? But to get there, we need to do some level setting. We need to go over some basics, talk about very briefly how HIPAA applies to public health. There have been some waivers issued, so what do they do? What is the impact of other federal law and state law considerations? And you'll see it's listed second to last bullet, but really we discussed that pretty much throughout the presentation. It pops up here and there. And then we're going to go through most of the FAQs that we've answered to date. We've been developing these FAQs over the past week and a half or so. They're on our website. Any link that we have to them in this PowerPoint is in red. So when the slides are posted, you'll have access to this entire presentation, and the FAQs are already in the website. So let's talk about some HIPAA basics so we all get on the same page. HIPAA sets minimum national standards for privacy and security and even serves as a best practice for those not directly covered by HIPAA. HIPAA gives patients rights regarding their health information, such as access rights to their medical records. It generally applies to most healthcare providers and to health plans, which are called covered entities. And the way HIPAA works is that it starts with a general prohibition and then builds on it with a labyrinth of exceptions. So who does HIPAA apply to? It applies to covered entities. As I just mentioned, most healthcare providers, but only if they transmit information in electronic form and in connection with an electronic standard that HHS has adopted. Health plans and healthcare clearinghouses, which translate and reformat transactions. So let's talk about what does this mean in terms of public health. The health department's clinic that provides health services to individuals and builds health plans electronically for those services covered by HIPAA. Even a health department offers health services such as vaccinations or sexually transmitted disease screening. Even in furtherance of health goals, it still may be covered by HIPAA. These health services are HIPAA covered if the clinic bills electronically or utilizes any of the standard transactions in the administrative or financial aspects of healthcare delivery. If the health department operates a health plan, such as Medicaid or the Children's Health Insurance Program, those relevant components are covered by HIPAA. And I'll just mention briefly, business associates are now directly covered by HIPAA as well. Those are organizations that perform functions on behalf of the covered entity or provide services to the covered entity that involve the covered entity's protected health information. Examples include billing services, document destruction services, outside attorneys, and more. So public health finds itself juggling multiple roles. Public health works to protect the public's health, and it also provides primary health care. It protects privacy while it also informs the public. So public health has competing goals and must juggle all of these different goals as it performs its mission. So how does HIPAA apply to your health department? This is the first question you want to ask. This is absolutely essential to know. This guides your data sharing research in really answering every single question. Does it apply to your entire health department, some of it, or none of it? So to understand these questions, we're going to take some background on HIPAA coverage. So imagine if your health department just has one covered component. You operate a clinic, and with that clinic, you bill health plans electronically, you check eligibility, you do prior authorization electronically. Just that one bit of a HIPAA covered entity makes your entire health department completely covered by HIPAA, and it stays completely covered by HIPAA by default unless your health department takes affirmative action to become a hybrid entity. That action is adopting a hybrid entity policy in writing, and this is where HIPAA allows covered entities to assess exactly where they have covered components and where they do not, and restrict HIPAA to only those covered components. Again, that is called becoming a hybrid entity. So again, by default, your health department is a single covered, fully covered entity unless you take action to become a hybrid entity. So talk to your privacy officer, talk with your attorney, find out if your health department is a hybrid entity. And even if you are hybrid, you still have to think about other federal laws and state laws. So whether HIPAA applies to a health department's communicable disease program depends on whether the organization of the health department and whether it has declared itself a hybrid entity and designated covered components and non-covered components. If the communicable disease program is within the covered component of a hybrid entity or within a fully covered health department, then HIPAA applies to the communicable disease program. Thus, the advantage of the hybrid designation is that HIPAA's stringent disclosure requirements do not apply to core public health functions. We did a survey a couple years ago of state public health departments, and you'll see that the vast majority are hybrid entities. We did have 16 states that did not respond, and there are many benefits involved in becoming a hybrid entity. So moving on to waivers, and I'm going really fast because we have a lot of slides to cover, and the plan is to end the presentation component at the half hour so that we do leave a half hour for questions. So in response to President Trump's declaration of a nationwide emergency concerning COVID-19 and HHS Secretary Azar's declaration of a public health emergency, Secretary Azar issued a limited waiver effective March 15, 2020, waiving sanctions and penalties against a covered hospital that does not comply with specific portions of a HIPAA privacy rule. So you'll want to, if you have a covered hospital, that waiver may be of some benefit to you. For the majority of health departments, it probably will not provide much assistance. Effective March 17, 2020, OCR issued a notification of enforcement discretion for telehealth remote communications during the COVID-19 nationwide public health emergency. OCR states that it will not impose penalties for noncompliance with HIPAA's privacy rule against healthcare providers in connection with their good faith use of telehealth during the COVID-19 nationwide public health emergency. Review the guidance that was recently issued to see the types of telehealth applications that are acceptable and those that are not. So within the limited waiver, HHS makes clear that compliance with the HIPAA security rules, administrative, physical, and technical safeguards are still required to protect patient information against intentional or unintentional impermissible uses and disclosures. However, the Secretary of HHS has authority to waive sanctions and penalties when the President declares an emergency or disaster and the HHS Secretary declares a public health emergency. Further, OCR evaluates complaints on a case-by-case basis and exercises its discretion when it takes enforcement action. If you follow the paper, you'll see that there have been a number of intrusions and breaches recently in healthcare. So it can happen anytime, and we need to keep our security up even during an emergency. So we're going to turn to approach. With every data disclosure question, you want to first go to your public health attorney or your privacy officer to see if your health department is a hybrid entity. You need to find out if your disease surveillance, investigation, and intervention functions within your health department are covered by HIPAA. Then you want to determine if there are any state laws that also have to be followed, particularly in areas such as mental health. Where HIPAA does not apply, where you're not a HIPAA-covered entity, then you're just following state law. Everybody is also following other federal laws that apply. A really good example is the substance use disorder data regulations in 42 CFR Part 2. So you want to approach data privacy law like a layer cake. Each category of law is a different layer. You have HIPAA, state law, and other federal law. So what are some examples of HIPAA-covered COVID-19 protected health information? What are we talking about that is protected by HIPAA? Since every state's law is different and oftentimes states model their policy after HIPAA, we're structuring the Q&As around what HIPAA provides. So obviously, COVID-19 PHI includes an individual-specific test results, details about a particular patient, details about that patient's underlying conditions, et cetera. What's not so obvious is that PHI is also your COVID-19 counts by county. It's also the release of any data that pertains to a time period for less than 1 year. HIPAA's safe harbor rule makes that PHI as well. So we're going to start now taking a deeper dive into the FAQs that we have received so far and have answered questions from your peers about disclosure. For every single FAQ, you're going to need to consult your own state's law and other applicable federal law. So the question here is around the public health exception in HIPAA. And HIPAA permits public health to share COVID-19 PHI, such as COVID-19 positive patient name and address, underlying conditions, to another public health authority for the core public health function of preventing or controlling disease, injury, or disability. Here, public health is working to control the spread of COVID-19. HIPAA also permits public health to share COVID-19 PHI with any persons at risk of infection or spreading disease if it's authorized under law, another law, such as state law. So if a health department's communicable disease program is covered by HIPAA, may it share COVID-19 PHI for treatment purposes? HIPAA permits a health department to share a patient's COVID-19 PHI without patient authorization for its own treatment purposes, such as from the disease control and prevention program to the public health clinic. HIPAA also permits a health department to share a patient's COVID-19 PHI without patient authorization for treatment purposes of another provider, such as from the disease control and prevention program to a hospital. Well, what about redisclosure? Does HIPAA have anything to say about redisclosure? Are there any prohibitions of redisclosing PHI that you did not create or does not, quote unquote, belong to you? The answer is that HIPAA and likely most state laws do not regulate use and disclosure based on data ownership. HIPAA regulates a covered healthcare provider's PHI use and disclosure according to the purpose of the activity. HIPAA permits covered health departments to disclose without patient authorization PHI about the patient is necessary to treat either the patient or a different patient. HIPAA does not prohibit disclosure of PHI for treatment solely because the information was created by another healthcare provider, such as a laboratory. HIPAA also permits covered health departments to share PHI with other healthcare providers for purposes of care coordination or management without HIPAA authorization. HIPAA considers care coordination and management part of treatment activities. Other federal laws or state laws may restrict the health department's redisclosure authority. For example, think about the federal substance use disorder regulations. They strictly limit redisclosure. State law may also impose limitations on disclosure for both covered and non-covered health departments. Health departments should examine state law to identify any state law limitations. We are hearing that some healthcare providers may be reluctant to redisclose health information that they did not create. This reticence may stem from older policy prohibiting this redisclosure. Addressing this question from an information management standpoint, the American Health Information Management Association recommends that providers redisclose PHI to other healthcare providers when it is necessary to ensure the health and safety of the patient. So now we're going to turn our attention to disclosures to the media. We have received numerous questions and requests for guidance around this topic. So if a health department's communicable disease program is not covered by HIPAA, the question is, may it release COVID-19 county-level case information to the press? And as I said a minute ago, most state health departments' disease prevention and control programs are not covered by HIPAA. So you're really looking at whether state law and other federal law or policy would allow the disclosure and what may be provided. You want to think about there's a real balance here. There are many important considerations for public health in the role of juggling its competing priorities and mission. It's important to release as much as possible to keep the public apprised and to have knowledge of what's going on, as is allowed by law, and as long as confidentiality is maintained and individuals are not identified. When you're not able to release a certain data features such as age or very high granularity of address, then you want to explain the rationale. You want to provide your legal reasoning and you want to provide a citation. These recommendations, as well as data release guidelines, come from guidance developed by ASTO, NACHO, and the Association of Healthcare Journalists. We have a link to this guidance in the slide and in our FAQs on the website. The guidance is excellent in terms of what public health, how public health might work with journalists, how the role of journalists receiving information from public health and providing context. And it offers guidance around balancing some of the information about individual victims, such as age, gender, location of victim's address, time of death or disease, place of death, etc. This guidance may be very helpful to you as you're making these difficult decisions. So, if a health department's communicable disease program is covered by HIPAA, what does HIPAA have to say about the release of county-level information? Well, HIPAA is really not helpful in this scenario. HIPAA safe harbor method would not allow you to release county-level information on a daily basis. It would have to be nothing smaller than a year. You can evaluate using an expert method, which is where a fully covered health department might utilize an expert to evaluate the degree of risk the information proposed to be disclosed, alone or in combination with other reasonably available information, could be used to identify an individual. Excuse me. If the expert concludes that the risk of identification is very small, the health department may disclose accordingly, and then the expert documents the results. And it's a pretty high standard to be a HIPAA expert. It is someone with appropriate knowledge of and experience with generally accepted statistical and scientific principles and methods for rendering information not individually identifiable. Many health officers don't typically have resources to engage a HIPAA statistical expert, nor are they able to indemnify the expert, which is always required. A few health departments have internal experts. If a fully covered health department cannot take advantage of the two de-identification methods to share the number of positive COVID-19 cases per day by county, but believes that the information is essential for the people who live in its jurisdiction, it might consider alternatives that would avoid adverse health consequences. For example, fully HIPAA-covered health departments might consider HIPAA's exception to its general rule of state preemption, which is that HIPAA preempts any contrary provision of state law. So where HIPAA and state law conflict, HIPAA generally preempts state law. But under certain circumstances, HIPAA preemption does not apply where the state law provides for the conduct of public health surveillance, investigation, or intervention. In particular, HIPAA would not control how state and local health departments implement state laws to monitor COVID-19. Accordingly, the argument is that HIPAA does not limit a health department's disclosure of information as it conducts COVID-19 related surveillance, investigation, and intervention pursuant to state law. This approach is a novel and emerging legal theory to address the COVID-19 pandemic. Please note that to date, we have identified no OCR guidance to this effect. This emergency situation could not have been anticipated and time is of the essence. We know that this is a very technical legal theory, and if you're interested in it further, you can find it laid out in FAQs on our website. So now we'll move to disclosures to first responders. We have received lots of questions in this area. So if the health department's communicable disease program is covered by HIPAA, may it release COVID-19 PHI to first responders? So for treatment, such as when an emergency medical transport personnel will need to provide treatment to an individual with COVID-19 while transporting that person to a hospital, that is permitted without patient authorization. It is also permitted to share COVID-19 PHI with first responders when there is a risk of infection and when it is authorized by state law. An example of this is where a county health department discloses identifiable COVID-19 information to a police officer or others to prevent or control the spread of COVID-19. A final area is when the disclosure is necessary to prevent or lessen a serious and imminent threat to the health and safety of a person or the public. For example, a health department may share PHI about individuals who have tested positive for COVID-19 to first responders if the health department believes in good faith that it's necessary to prevent or minimize the threat of imminent exposure in discharging their duties. OCR issued recent guidance to this effect, and it is also available through the FAQ on our website, that states that healthcare professionals must follow professional ethical standards and state law in making these good faith determinations. OCR also offers a best practice of how to share COVID-19 PHI with first responders. And you'll see that where it is authorized by law, such as a state law, a fully covered health department could provide a list of names and addresses of all individuals who've tested positive or received treatment for COVID-19 to the EMS dispatch. So then on a per-call basis, dispatch uses the information to inform the personnel, EMS personnel, actually responding to the specific call so that they can take extra precautions to prevent the spread of COVID-19. Can or must an emergency responder be notified if they have assisted with transporting an individual who tests positive for COVID-19? The answer is yes. There is CDC, there's a Public Health Service Act law and CDC guidance around this, see our FAQs. I see I have 5 more minutes in my presentation, so I'm just going to go really quickly to get through this. Their question came in to us, may a health department provide the names and residential addresses of all positive COVID-19 cases to all first responders? And the answer is really not clear. When we have questions like this where you have competing interests and you have discretion involved, we recommend a framework involved of can I, must I, should I, and you evaluate the legal considerations about the disclosure. You look to see if a health officer is required to disclose the answer, and the health officer always has a lot of discretion in disclosing this information. And then the biggest part of discretion comes around should I, and it's balanced based on professional judgment with input from team members with subject matter expertise. And the health officer weighs the competing interests, balancing the individual's interest in privacy against protecting EMS employees, the healthcare system, and the general public. Next question, is it appropriate for public health to request consent from asymptomatic medium-risk travelers to provide their name and residential address location to emergency responders in order to protect the health of EMS personnel? Like the prior question, this answer is not clear, and we recommend that the health officer with staff work through the can I, must I, should I. Does HIPAA allow sharing of COVID-19 PHI with law enforcement? HIPAA provides several options for sharing PHI with law enforcement without patient authorization. One of the areas to always look at is whether it's a required by law disclosure, such as state law. So that is to say, if you have a state law that requires disclosure of the COVID-19 results of law enforcement, you can rely on that other state law. Public health can share with persons at risk of contracting or spreading a disease or condition if they are authorized under law to notify the person, here, law enforcement. Sharing can occur to prevent or lessen a serious and imminent threat to the health and safety of a person. Health departments can also disclose patients' health information to anyone who is in a position to prevent or lessen the serious and imminent threat, including family, friends, caregivers, and law enforcement. We're going to move to disclosure of PHI in judicial and administrative proceedings. Health departments should respond to a court or administrative tribunal's order, but only to the extent as specified in the order. Only the minimum necessary PHI may be disclosed, and you should also look at your federal and state law to make sure you're in compliance with those legal requirements, particularly around the substance use disorder regulations. So if you receive a request for PHI in a judicial or administrative process that does not have a court order, so you receive a subpoena, discovery request, or some other lawful process, can you turn over the PHI in response? The answer is not just based on the bare subpoena or lawful process. You have to follow the requirements of either obtaining satisfactory assurances or trying to get a qualified protective order. So there's a process in HIPAA that has to be followed, and it's detailed in our FAQ. If you receive a request for PHI through FOIA, how do you approach it? Well, as a health department, you'll have to comply with both open records laws as well as state and federal confidentiality and privacy law. We include a resource on it's called the Open Government Guide, and there's a link there in red which has a summary and law for each of the states and guidance to help you figure out what to disclose. For those health departments that are fully covered by HIPAA, you can only release PHI that is required to be released by applicable state public records law. Disclosures to close contacts. What PHI can be shared with a COVID-19 patient's friends or family? The HIPAA privacy rule specifically permits covered entities to share information that is directly relevant to the involvement of a spouse, family members, friends, or other persons identified by a patient. Even when the patient is not present or is otherwise incapacitated, a covered entity may share this information with those with whom the patient has identified if it is determined in exercising professional judgment that doing so would be in the patient's best interest. These disclosures are not subject to the minimum minimum necessary standard, which requires covered entities to limit the use or disclosure of PHI to the minimum necessary to accomplish the intended purpose. Additionally, people in close contact with someone who is infected with the virus are at higher risk of becoming infected themselves and of potentially further infecting others. Closely watching these contacts after exposure to an infected person will help them get care and treatment and will prevent further transmission of the virus. The privacy rule permits covered entities to disclose necessary PHI without individual authorization to persons at risk of contracting or spreading disease if other law, such as state law, authorizes the covered entity to notify such persons to prevent or control the spread of the disease or to carry out public health interventions or investigations. The minimum necessary standard does apply in this situation. So, is it appropriate for public health agencies to share protected health information of an employee with other employees at the same place of work during this COVID-19 crisis? The HIPAA considerations are around the legitimate need for public health authorities to access PHI that is necessary to carry out their public health mission. The privacy rule also permits a covered entity, that is a public health authority, to use PHI for the purpose of preventing or controlling disease. It also permits covered entities to disclose PHI without individual authorization to persons at risk of contracting or spreading disease if other law, such as state law, authorizes the disclosure. Yeah, I've got to toggle and move my slides up a little bit. So now we come to questions, a series of questions about disclosures through an HIE. May a health department share COVID-19 test results with healthcare providers and other health departments through an HIE for treatment, care coordination, and public health activities? The answer is that HIPAA permits a covered health department to share COVID-19 results through an HIE or intermediary if they are permitted to share PHI directly with the other organizations. You need a signed business associate agreement which obligates the health information exchange to protect the information. Generally, all health departments must comply with state law and other federal law regarding confidentiality of information. So we have a resource link there embedded in the slide and in the FAQ that takes you to state health IT and consent laws that are relevant to determining whether there are other legal requirements before the information can be shared through an HIE and how it needs to be shared to meet those other requirements. We're hearing that there is some concern about liability for other HIE participants. OCR has addressed this concern in their own FAQs, and they state that a covered entity, such as a covered health department, is not liable for a disclosure based on the noncompliance of anybody else participating in the HIE as long as you, the covered health department, have complied with the privacy rule yourself. I also would commend health departments who are considering utilizing an HIE to share their COVID-19 PHI widely to look at state law. Interestingly, many states grant immunity to HIE participants, and we have found an excellent law review, or a journal article, I should say, and it is linked through the resource there on that slide. We also understand that there's some concern if the HIE itself might breach the COVID-19 PHI, would the health department be responsible? And again, where a covered health department has an appropriate business associate agreement in place with the HIE, it is not going to be directly liable for the HIE's HIPAA violations. The business associate agreement itself obligates the HIE to safeguard the COVID-19 results and to report the noncompliance back to the covered health department. And again, I would recommend that interested health departments look at state law to see if they might be immune from utilizing an HIE to share broadly their COVID-19 lab results. So we have resources that are developing every day. We have a section on our network website, COVID-19 resources. Within that, we have our COVID data FAQs that we are adding new ones every day. We have articles. We have a toolbox that is coming. I developed a quick list of sections of HIPAA that are frequently being used in COVID-19. We should have that up in the toolbox within a day or two. We also have resources around legal emergency preparedness, a primer, we have crisis standards of care, and we're doing weekly COVID webinars. To help you find other relevant federal laws, we have a resource on our website that you'll be able to link to from here called Federal Privacy Law Snapshots. And we also have a resource that we created along with data across sectors for health called the Legal Bibliography. That is a treasure trove of federal and state law itself as well as resources. So I need to pass it back to Jennifer or Charles for the Q&A.
Okay. Hi. I think I can be heard now, and we're going to move now into the Q&A section. We have been, or session, and we have been getting a lot of wonderful questions through the Q&A panel. If you have any additional questions, please go ahead, open that panel, type in your question, and click send. I'm going to start with a question we received about contract tracing and whether or not you can use a person's name when speaking to contacts.
Thanks, Jennifer. So when you're thinking about contact tracing, and if you're HIPAA covered, you can use the PHI that's necessary to do that contact tracing, but you need to figure out and balance exactly what is absolutely required. It may be enough to describe the location and the time. It's a matter of discretion, and if you are not covered by HIPAA, it's going to be a matter of state law.
Okay, thank you, Sallie. Next question is, and this one I think goes a little away from some of the topics, but is interesting, and maybe you have some thoughts, is how can COVID-19 data be used in private cloud-based GIS mapping applications and maintain the HIPAA compliance? Any thoughts on that?
Sure, that is a multi-layered question. So,
yeah.
So in a private cloud, so we're talking about cloud services. So you're going to need a business associate agreement with the cloud service provider for that PHI. And if you're HIPAA covered, that is to say, if you're not HIPAA covered, you're going to want a good agreement that protects the uses and disclosures and the security of that health information. You're probably also going to want a few additional terms that are unique to cloud providers around security primarily, as well as other terms and conditions. And so even though you are talking about GIS and mapping, each of the dots on a map reflects a very granular location of a patient. If you are if you're actually reflecting these dots, that is identifiable information. So you're going to simply treat it as you treat all PHI.
Okay, thank you. Another one goes to notifications. So the question is, if there's a positive case in a facility, and I assume it's maybe a healthcare facility or maybe a nursing home or some type of facility where there may be a positive case, what do you recommend a covered entity provide to press and other family or friends when making notification for that positive case? People who may have been in the same facility.
Okay. So this is a little different than public health. This is for a healthcare provider notifying family and friends. And so HIPAA does permit a covered entity to share information that's directly relevant to the involvement of the spouse, family members, or friends. The disclosures are not subject to the minimum necessary standard. It requires the exercise of the healthcare provider's professional judgment around what would be in the patient's best interest.
And I'll just add, since I think the question is sort of multi-layered, so there might be involvement of family and friends in treatment, but then it might go to how you're contacting people related to a positive case in the facility and those that might have had close contact. So in that case, I think that would be the provider contacting the health department, letting them know of this potential close contact, and then the health department taking the initiative to do the contact tracing, to follow up and provide necessary information to people who might have been exposed.
Excellent. Thanks, Jennifer.
Yeah. The next question is, if a person tests positive for COVID-19, what information can a local public health agency disclose to the positive case's employer to be able to gather contact information of employees who may have been in contact with the case? And you touched on the fact that, we can provide information to employers. Do you have anything to say about what kinds of disclosures can be made in those cases?
Sure. So when you're talking with an employer, you're going to have to disclose enough information so that you can alert the employer will need to partner with you to identify who was in contact with the employee who has COVID-19. And so you're going to have to share detailed information with the employer, I would imagine, so that they can figure out who was on that person's shift or who worked in proximity, and then evaluate the kinds of information going forward that you share with the individual. You may not necessarily need to share the positive COVID-19 employee's name with the coworkers, but by indicating, you may say that this person worked on their shift or worked in proximity, they may be able to figure it out, but it's still important to apply the balance and share the information needed to accomplish the public health purpose, and really no more than that. Great.
The next question, and I think this sums up a lot of questions that many people asked, is that health departments are under a lot of pressure to release details to the media about positive cases, such as age range, hospitalization status, zip codes, transmission status, gender, lots of zip code, I think I said that, lots of different information. Many times the health departments are not hybrid entities. They might be fully covered HIPAA entities and are concerned about what types of information they can release.
Sure. This is a challenge, and it's particularly challenging to work through this at the very time of the emergency. So we see the public and the media getting hungrier and hungrier for more and more details as this pandemic moves up the curve. So it's truly a balance. Think about what is most important to your community. So you cannot be equally granular in each area. In area, I mean age, gender, location, time of disease occurrence or death. You need to evaluate what is most important, and really here I'm talking about a non-HIPAA covered health department. Jennifer, I'll talk about HIPAA covered in a minute, because HIPAA covered is really no discretion. But with non-HIPAA covered, you want to weigh the different types of data and figure out what would mean the most to your community and place an emphasis on that. So if age is really important and you work with your epidemiologists or others in your health department, your own statisticians, and you're able to release, say, even year of age, but you have a big population, and you're releasing location level at a much higher level, and your epidemiologist or your statistician believes that you are not releasing information that could lead to the re-identification of any patient, then that's really the way to go. I like the guidelines and the principles behind the guidance developed by the Association of Healthcare Journalists. It's on their website. It's really all about the balance. Now with HIPAA, unless you have a HIPAA expert who can help you figure out how to do this weighing that the non-covered entities can do, then you're really kind of stuck with safe harbor unless you determine that it's so essential to the health of your community and to share the information. And we've identified a legal argument that's plausible. But really the area where you'll have much more useful information and fuller, more transparent communication to the media is from your health department's communicable disease programs that are not HIPAA covered.
Okay, thank you. The next question, as it relates to contact tracing, when you're reaching out to contacts, is it appropriate to leave a phone message, especially if you've tried to reach the individual with no response? And the example of the phone message they said is you may have been exposed to a COVID-19 case. Thoughts on that?
That's a good question. We have not received that question yet, and it's, I think I would imagine I think I would need to think through it, but just off the top of my head, I think I would tend to follow the other policies that my health department has in place about phone messages, about appointments, with the caveat that leaving a specific diagnosis is such, COVID-19 is so concerning. I think I would keep it more in line with my existing policy around please call the health department. Jennifer, do you have thoughts?
So my thought is that, HIPAA does have restrictions on how information can be shared. You can't just, leave a message at someone's door, tape it to their front door. You have to, have it sealed in an envelope and put in a place, like a mailbox or somewhere the person is likely to receive it. And so I think that in phone messages, if we're talking about a HIPAA-covered entity, you also, at least from a treatment standpoint, are not allowed to leave a voice message that provides protected health information in the message itself. Rather, just have, like you said, a more generic message to call the provider or call the health department. And so I think in these cases, leave a message, tell them to call, but err on the side of caution as to what information. Even though in this scenario, this is a contact being made to someone who may have been a close contact of someone in a positive case, but that in and of itself might mean that they are indeed a positive case themselves. So I'd err on the side of caution, like Sallie said. Okay. The next question, if a public health agency has access to PHI, can it share the PHI with a public housing agency and private care facilities that are providing housing to COVID-19 positive homeless during recovery who have underlying health conditions that must be known to the housing provider. So maybe, Sallie, you want me to take this one? I've done a little more.
Sure.
So there is some guidance that has been issued by HUD regarding the Homeless Management Information System. We are working to develop some more information around these types of questions, but we have not gotten to that yet, so I don't want to speak directly to it, but just know that we are working to develop out this area of content more. And we can provide a link. I'll put a link in the chat box to the guidance, so if you know, these are very urgent questions for you, you can go ahead and review that yourself in the meantime. So I'll do that towards the end of the webinar. So the next question that we have is so this one is a situation where an employee of a tribal enterprise was alleging that a coworker was COVID-19 positive, and the tribe reached out to the local health department where the employee may have received a positive test, but the local health department would not provide information to the tribe. And the question was, does the local health department need to provide this information to the tribe, and how can tribal employees assure that they receive it?
Okay, this is another complicated situation.
Mm-hmm.
So it sounds like the tribe is reaching to the state public health authority as an employer as opposed to a public health authority. So if an employer approaches a public health authority and wants to know if one of its employees has a positive test result, you would want to follow your internal policies around disclosure of health information to an employer. Now, if the tribe in it came to the state public health authority with its public health authority hat and furthering its public health mission, then state public health authority can share COVID-19 PHI with another public health authority for the purpose of public health disease investigation and intervention. But in the role of employers, that would not be permissible in a HIPAA world, absent patient authorization and in accordance with state law and any other law and tribal law as well.
Okay, thank you. I just want to make a quick note. I had a lot of questions asking about links to the resources, and I just want people to know that we will, in fact, have the slides made available on the network's website shortly after the webinar is complete, and you will be able to download those slides, and everywhere there was red text in the slides mean that there was a link to a resource. So if there are resources that you saw mentioned during the webinar, you'll be able to get those through the slides pretty quickly. So for those searching for certain documents that Sallie might have referenced, you'll be able to get that through that. I think we have time for just a few more questions. So the next question is, how, if at all, does HIPAA apply to non-healthcare organizations and or maybe even non-HIPAA covered organizations, and can an employer disclose identifiable patient information if they have that? Kind of a two-part question.
Yeah. HIPAA only covers covered entities and their business associates. So HIPAA covers providers who are billing electronically or using those other standard transactions to participate in the claim payment lifecycle. They're submitting transactions to find out if the patient has health insurance, to find out is prior authorization required. They're getting paid through the transaction. That's a HIPAA-covered provider. A health plan, your Medicaid or your CHIPP, your business associates are attorneys, billing agencies, utilization review companies that are using the covered entity's protected health information to support them. And so covered entity has to have a patient authorization generally to share information with an employee's employer. Now, if that employer is not covered by HIPAA and HIPAA is not governing them, there are other laws within that are jurisdiction specific that would need to be evaluated to see if individual consent is required. And in many jurisdictions, that consent is required. You might look to the legal bibliography as well, as well as the federal snapshots that we have links for to see if consent is required in your jurisdiction.
Okay. Another question that we received, I think this might be the last one we have time for, is the person said, thank you for mentioning the important role that epidemiologists play in deciding how granular data shared should be or can be, and they asked whether there are any laws or legal guidance that clarify that epidemiologists are the ones that will guide this decision-making. There's
nothing that says that it only may be epidemiologists. In fact, I've seen other experts come from a variety of fields. Mathematicians, for example. There are various types of statisticians, privacy scientists. They just have to have, I think the best place to look for the kind of expertise that you need is to look at our resource on our website. It's within our de-identification toolkit, and there's a fact sheet that describes HIPAA's expert method, and it tells you the kind of education that's required and the kind of experience that's required. So epidemiologists often have the appropriate type of education so that they can, and the experience, because what they need to be able to do is to understand the data, the target data to be released, and have the expertise to really attack the data to see how many uniques are in the data, to overlay that with their local demographics, other publicly available data, to see how many people, what the resulting data set would be in comparison to the entire number of people within the geographic area, so that they can get an actual risk of re-identification, so that they can ensure that the information is only disclosed at an appropriate risk level to maintain that privacy.
Okay. Thank you, Sallie. I'm going to pass it off to Charles now.
Thank you, Jennifer, and thank you, Sallie, for presenting. And thank you all to our attendees for participating in today's webinar. Just a few final notes. If you did submit a question that did not get addressed during our Q&A session, don't worry, we'll be reaching out to you to ensure your questions get answered. Also, all attendees will be receiving an email from the network with the video playback of this webinar, as well as a link to our brief webinar survey. The survey takes just 1 minute to fill out and it provides us with some great insights, especially in regards to what topics you would be interested in for future webinars. Join us next Monday for a webinar on COVID-19 and housing insecurity, where we will review the actions taken by the federal government to prevent foreclosure. and by state and local governments to prevent evictions during the COVID-19 pandemic. Learn more about the webinar and view the network's collection of resources on the pandemic at networkforphl.org/COVID-19. Finally, registration is still open for the 2020 Public Health Law Conference, where attendees will learn legal and policy tools to address fundamental drivers of inequity, promote health and well-being, and save lives. You won't want to miss it. So that concludes today's webinar. Thank you all for attending. Have a great rest of your day.